Some of the best practice strategies that I've been exposed to at the institutions that I've worked at that I feel most effective, I'd like to share them with you now. Some of the things that have been most effective are very rapid cycle feedback. So at one of the institutions I've worked with, we tracked on each individual case time to assessment, time to CT scan, and time to provision of TPA so that we could calculate door to CT and door to needle time. And we provided that feedback to the physician group on a case-by-case basis. So a few days after your case, you'd get a brief report back with your times that were abstracted from a time log that was kept. And the results were quite striking. You know, very frequently you get a time report back saying that it took you 35 minutes to get to CT on that case, and almost universally everyone's response was, "I thought we went there right away." So it just goes to show that in the heat of the moment, when you're doing what's sometimes been called a stroke code or working on a thrombolysis case, there's so many other things going on that it's hard to objectively recognize the time it takes to do things and possible delays. And so that's one strategy that we found very effective. And without any other specific changes in our workflow, just by alone knowing the times, we saw a fairly dramatic drop in our door to CT time, just based on this simple step alone of being more aware of what our times really are. Another strategy that we put in place at my hospital was based on a problem we noticed, whereby the time to register the patient in the emergency room was taking as long as 10 to 15 minutes for our admitting department to enter all the information about the patient and date of birth and other identifier information. And this was inhibiting us getting to a CT scan and completing the CT scan in a rapid manner because we were not able to scan the patient without a registration entry into the system. And the way we addressed that was to work with our hospital administrators to create a system whereby we could register a patient similar to an unknown patient or an acute trauma patient. We borrowed some of the protocols used by our trauma team, so that we could register the patient under a holder number, anonymous holder number, that would allow us to do the CT scan, and then we could link that number with a patient's identifiable information once they'd finished the registration process, which sometimes would happen after the CT scan.